Hello, friends. Here we will be talking about the 2021 MRSA guidelines which have come from UK. A lot of committees sat together and gave them, and they have divided into the manifestations and have given you the choices. So, for abscesses, they have said it's surgical, drain them, and there are criteria as when to use an antibiotic. And when you are trying to use an antibiotic, you can use the oral options, cotrimoxazole and clindamycin. But if there is a severe skin and soft tissue infection, then vancomycin comes into the picture. It's a drug of choice. Or alternatively, you can use teicoplanin. Teicoplanin is something which is not available in the US but is extensively used in Europe. So the European guidelines mention them very frequently, and we Indians are also frequently using teicoplanin. What are the alternatives you have? Linezolid, especially if you want an oral option, daptomycin, and tigecycline, which is an approved drug for skin and soft tissue infections. There are other agents as well which has MRSA activity like ceftaroline, delafloxacin, ortivancin, televancin. So these are all considered alternatives. What about urinary tract infection? The first word, it's uncommon. So if you get a staph in the urine, then it is generally a disseminated infection which has also involved the kidneys. Primary UTI is very, very uncommon. It might happen with catheters, and the more common organism probably would be enterococci. If it's a catheter-associated UTI and MRSA is isolated, you can just use a single dose of vancomycin, and that also if gentamicin resistance has been seen. And aminoglycosides have excellent urinary penetration, and maybe a single dose gentamicin there might help. Linezolid should be avoided, and that is because the excretion of linezolid is very little, around 30% in the urine, and so it might not be dependable. You have the oral alternatives when you need, and these are doxycycline, trimethoprim sulfamethoxazole, and ciprofloxacin. What about bones and joints? Again, vancomycin, deep-seated infection, it is preferred, and you can use teicoplanin. Daptomycin and linezolid are alternatives. And for the oral options, you have clindamycin, trimethoprim sulfamethoxazole, linezolid, and doxycycline. In bacteremia, it's vanco. So whenever we have a serious life-threatening gram-positive septicemia due to MRSA, vancomycin is a drug of choice. Alternatively, they have given the option of linezolid, and as next line, there is daptomycin and teicoplanin. So in infective endocarditis, if you translate, there is a separate set of guidelines for that. Vancomycin would probably be the first in the list to be used. In pneumonia, here linezolid comes into the picture. So one infection where probably it's kind of comparable to vanco is in pneumonia. And you might consider clindamycin and rifampicin. And this is interesting because they might have some toxin neutralizing value. They may decrease the production of toxins. And so these two drugs might actually be useful as a combination therapy to decrease the toxin production. Ear, nose, throat infections, vancomycin, alternatively you can use teicoplanin, and orally trimethoprim sulfamethoxazole or doxycycline. Intracranial or spinal, it is vancomycin. Teicoplanin is not talked of here, or an alternative could be linezolid. Meningitis, only vancomycin has been mentioned, and one may add rifampicin to vancomycin. Linezolid and clindamycin should be avoided. So when meningitis are involved, linezolid is not a good choice. Similarly, the other common agent, clindamycin, is not a good choice. To sum it up, whenever we have a serious infection, MRSA, vancomycin is a drug of choice. Teicoplanin is a suitable alternative which is available, or it could be a new fluoroquinolones. Levonorefloxacin is not mentioned here, but that's one agent available both as IV and oral formulation. And then we have the oral agents which are active. Linezolid is interesting, both IV and oral formulations, and they can be used whenever the clinical situation demands.